Hello everyone, today we will discuss about abdominal aortic aneurysm. Please like and subscribe my channel. So, for abdominal aortic aneurysm, the maximal diameter should be more than equal to 3 centimeter for infrarenal aorta and more than equal to 3.5 centimeter for suprarenal aorta. Now, the risk factors for the development of abdominal aortic aneurysm, smoking is the largest. Other risk factors include male sex, if the age is more than 60, atherosclerosis, coronary artery disease is a bigger risk factor compared to peripheral artery disease, any family history of abdominal aortic aneurysm, if there is presence of any other arterial aneurysm like iliac, femoral, popliteal, intracranial, if there's a connective tissue disorder, as connective tissue disorder weakens the wall of aorta and it increases the risk of development of abdominal aortic aneurysm in the future if there's any family history, if there's any prior history of aortic trauma like aortic dissection, aortic surgery, or instrumentation. The other risk factors are those which causes aneurysm rupture. Now, again, the greatest risk factor for aneurysm rupture is smoking, as smoking increases the inflammation of the wall of aorta by activating metallic proteinases, and this weakens the wall of aorta. So it is the greatest risk factor for development as well as aneurysm rupture. Second is if there is a large aneurysm diameter like more than equal to 5.5 centimeter, or if the expansion rate is more than 1 centimeter per year or more than 0.5 centimeter in 6 months. Now, hypertension is a risk factor for aneurysm rupture, but not for aneurysm development. Very important to know. Now, male sex was the risk factor for aneurysm development as compared to female sex is the risk factor for aneurysm rupture. If the aneurysm is having symptoms, it also increases the risk of rupture. The protective factors for the development of abdominal aortic aneurysm is the female sex. Remember, female sex is a risk factor for aneurysm rupture, but is a protective risk factor for development. Other protective factors include if the person is not from a white population, diabetes, as diabetes increases the extracellular matrix in the aorta, preventing aneurysm development. Moderate alcohol consumption is also a protective risk factor because alcohol increases the HDL, which decreases the risk of atherosclerosis formation and thus preventing abdominal aortic aneurysm development. Niacin is also a protective factor because it is an antioxidant and it decreases the inflammation. Now, the majority of the people with abdominal aortic aneurysm do not have symptoms. Younger patients tend to have symptoms compared to older people. If there are symptoms, they can be of a non-ruptured abdominal aortic aneurysm or a ruptured abdominal aortic aneurysm. For a non-ruptured abdominal aortic aneurysm, the most common symptom is abdominal back or flank pain as compared for ruptured. It presents in 50% of the people with a triad of acute abdominal pain, abdominal distension due to blood leakage, and hemodynamic instability. While rest of the people with aneurysm rupture do not have symptoms because the hematoma forms acutely and it guards the further leakage of blood, which delays the establishment of hemodynamic instability in people with a ruptured abdominal aortic aneurysm. Now, the diagnosis is very important of abdominal aortic aneurysm as it can cause mortality in a quick time, even when the patient have risk factors, history, and physical examination show signs of abdominal aortic aneurysm, still the patient need to go for an imaging. For diagnosis, we see if the patient is asymptomatic or is symptomatic. If the patient is asymptomatic, we diagnose by doing an abdominal ultrasound. If the patient is symptomatic, we see if the patient is hemodynamically stable or hemodynamically unstable. If the patient is hemodynamically stable, the investigation of choice is CT angiography. If the patient is hemodynamically unstable, we see if the patient has a prior established diagnosis of abdominal aortic aneurysm. If yes, then we go directly for intervention. However, if the patient is hemodynamically unstable but no prior established diagnosis of abdominal aortic aneurysm. Then we do a quick ultrasonography like a bedside and then go for intervention. Now, the favorable intervention is endovascular repair compared to open repair as it has more evidence of increased morbidity. However, rupture is a fatal complication and the mortality is very high of abdominal aortic aneurysm rupture despite of repair. Now, whenever you do an endovascular repair of abdominal aortic aneurysm, the renal function tests are deranged due to hypoperfusion during the repair as there is a lot of blood loss. So you monitor the renal function tests, and when the renal function tests are normal, then you do a repeat CT scan. This is very important to know. We do not do CT scan immediately. We wait for the renal function tests to become normal and then we do a CT scan. Complications of repair are due to hypoperfusion, which can be a myocardial infarction, respiratory failure, bowel ischemia, peripheral ischemia, and acute kidney injury. All these complications are due to hypoperfusion. Now let's talk about screening of abdominal aortic aneurysm. Grade 1A guideline is any male from 65 to 75 ever smoked. We do one-time abdominal ultrasonography. The second grade 2C guideline is any male from 65 to 75, whether smoked or not smoked ever in life, but has a strong family history of abdominal aortic aneurysm in the form of abdominal aortic aneurysm rupture, which causes death, or a repair of abdominal aortic aneurysm was done in any first degree relative. Then we do a one-time screening with abdominal ultrasonography. The third guideline is about women. If they have a strong family history of any abdominal aortic aneurysm repair or death due to abdominal aortic aneurysm rupture, based upon their values and preferences, we can do a one-time screening in women with abdominal ultrasonography. Otherwise, no screening is indicated for women. Now, if you see an aneurysm on abdominal ultrasound, the surveillance depends upon the size of the aneurysm. If you see the aneurysm size is 3 to 3.9 centimeter, then the repeat ultrasound is in 3 years. If the aneurysm size is from 4 to 4.9 centimeter, then we do the repeat ultrasound in 1 year. And if the aneurysm size was 5 to 5.4 centimeter, then we do the repeat ultrasound in 6 months. Thank you so much. Hopefully you liked it. Please like and subscribe.